5 injustices and 6 crises, which I think is a helpful way to frame the mess we're in at this moment. So the Poor People's Campaign has pointed out that there are 5 injustices. So the Poor People's Campaign is headed by Reverend William Barber and Reverend Liz Theo Harris, and is the preeminent civil rights effort in this moment. So the 5 injustices that they've listed are racism, poverty, the war economy, ecological devastation, and distorted morality. President Biden, in his inaugural address, said there are 6 crises: the COVID pandemic, climate change, growing inequity, racism, America's global standing, and attack on truth and democracy. So whether you think of it as 5 injustices or 6 crises, or you think of them together, the 5 injustices producing the 6 crises, that's a lot for any nation, and it's quite a mess. So I'm a social psychiatrist, and I'm just Martin, so you know who I am. I'm a social psychiatrist. I'm on faculty at New School, and I've written, the standard 100 papers and 8 books. And I've done research for since 1986 in poor communities, looking at what's going on. So I've been studying these crises as they have emerged. As a social psychiatrist, so it's, the fundamental thing about social psychiatry is that it's not about the biomedical model, which focuses on the person. It's about looking at the person in the context of larger social systems, and then thinking about how do those social systems work to produce health or disease. And so a fundamental tenet of social psychiatry is that social integration is the foundation of health, the true foundation of health, that groups of people can work together to take care of each other, and that there's a continuum of social integration across in any society, and comparing one society to another, and that the ends of this continuum are integration. You can see the things that characterize integration, and at the other end, when things have fallen apart, you have disintegration. And I would really just like to highlight one of these that I'm going to come back to, which is this commitment to the collective good. The we is a fundamental characteristic of how people talk about and think about their lives in an integrated setting. But in the context of disintegration, that sense that we're in this together has disappeared. And what emerges is the concern for self. So and you can see this in many, many ways in the discourse in the United States. I guess I should also comment about sentiments, that a sentiment in the classic definition is that a feeling about a symbol. So everybody feels pride when they see the same flag. And what's important about the United States in this moment of 5 injustices and 6 crises is that people are saluting different flags. There's a very troubling symptom of social disintegration in the country at large. So just to locate these 2 endpoints in another way, this is a photograph by Esther Bubley, part of the Pittsburgh Photographic Project. And so this is taken in the early 1950s at Hill House, important, later known, Irene Kaufman Settlement House, later known as Hill House. And what's important about this photo, or any photo that's trying to say, look, this is what integrated society looks like, is the sense of calm and the sense of ability to do work. The, it's really important, this concept, to social psychiatry. And the thesis is that a rich person in a disintegrated community will have worse health than a poor person in an integrated community. So that's how fundamental and shaping of this it is. So this is a poor community, yet people who grew up in that community have had good health and have been very productive citizens. This is, by contrast, a photo that I took a couple years ago in Old Town Baltimore, where things have fallen apart, and you can't imagine anybody being peaceful and painting, and there's no place for them to go paint. So what has torn this apart? There was a really interesting article in the New York Times that perhaps you saw, looking at why were Democratic presidents typically associated with better economy than Republicans. And so what I find interesting about this is that when you flip it and you look at it not by how much the economy was better, but by when they served. So this is more in order. With Reagan, we get the introduction of Reaganism, also known as neoliberalism, and that Margaret Thatcher sort of made the classic comment about that when she said there's no such thing as society. So the ideal of this is that there are no inhibitions on the market. Everybody can just do their thing, and the market delivers on everything that we need. So she says, I think we have gone through a period when too many children and people have been given to understand, I have a problem, it's the government's job to cope with it. Or I have a problem, I will go and get a grant to cope with it. I am homeless, the government must house me. And so they are casting their problems on society, and who is society? There is no such thing. There are individual men and women, and there are families, and no government can do anything except through people, and people look to themselves first. Uh, So there are two things about that. One is that there is society, so this is just a lie. And the second is that she doesn't actually mean there's no society. She means society is only going to take care of the wealthy. And what happens in that context is an array of policies that basically move all the wealth into the hands of a few, the growing wealth inequality that we all understand and have have seen. And that is accompanied by really a looting of the public treasury. So things like the public health workers get laid off. So we go into a pandemic with a public health workforce that's far below the level it should be at, as one example, but there are, of course, an infinite number. So one of the things that you notice is that the presidents that did really well in the economy are coming before Reaganism. Clinton did pretty well, but Obama, who's stuck really sort of as we get out to the tail end of it, didn't do well at all. So, so what's happened as a result of this? And is that if we think about these sort of ends of this continuum of social integration as not cross-sectionally but longitudinally, what we observed in Harlem and have documented in Harlem and other communities was that communities in the 1950s were much closer to the model. This is poor African American communities, but that they experienced a series of blows that were basically blows by the federal, state, and local policies. And these included the urban renewal program of the 1950s and 60s, deindustrialization, planned shrinkage, and gentrification. And that over that period of time, as we move from through these stages of collapse, the state of social organization is changing dramatically. What we saw in Harlem in the 1990s was what we called nonsense. And at that time, Doctors McCord and Friedman published a very important paper in the New England Journal of Medicine, which pointed out that a Black man in Harlem had less chance, a shorter life expectancy than did a man in Bangladesh, which was at that time the poorest country on earth. So so you walk down the street and you would see things and say, wait, that makes no sense. What's important is that the tragedies of Harlem or the Hill District or other poor minority communities are never contained in those communities. And so they will spread both geographically and up the social hierarchy. And so the attack on the Capitol, which I would put in this category of nonsense, is an example of how the kinds of pressures on society, the kind of destabilization of society that has been enacted in the United States over the past 70 years has pushed us from model towards collection. So when we think of cities, by we I mean the people I work with in the cities research group, we think about a sort of schematic with politicians in this triangle at the top, then civil society here, and hospitals we would put in this place, and then all the people who are divided into various kinds of communities. When disaster hits, what's important is that it blows apart the system of connections. And so people are disconnected from each other. Another way to look at it is in these sort of islands of people. And these islands are, I think, correctly depicted as these sort of pointy triangles. You might think of this in the feng shui sense, where the triangles are um, casting bad energy at each other. Because the groups are broken apart, they literally can't connect with each other, and they don't like each other. And this is, we saw up close and personal in Harlem, but think about the United States now. We're broken into many small groups. This is not a controversial statement, and the groups don't like each other. So what's important about Thatcher's "there is no society, we're just individuals" is that if you're going to drive society from the model, which is highly supported by central organizations like government, to a collection, you're on your own, you're also driving it from all the things that characterize the model towards nonsense. This is not widely recognized, but I think it's a better characterization that these are the troubles we see and the problems we have to solve. So just to go into all this whole list, in disintegration, we have few and weak leaders, small and fractured networks, differing sentiments, a concern for the self, the I, higher rates of illness and social pathology, and illness is more difficult to manage. In this model, I think what's important is that we're really mired in a social dysfunction. And part of that social dysfunction is that we can't get together. There's not that sense that, okay, we're a we and we have to sit down and we have to solve some problems. So the massive problems on that crisis list, like climate change, we have no way to do the collective work to figure out how we're going to solve that. And that's not just life-threatening for some most marginalized individuals, but that's actually life-threatening at the level of the extinction of our species and many other species. So this is a very profound situation. Uh, so what's the solution? I am convinced that the Moral Fusion Coalition proposed by the Poor People's Campaign is really the best possibility for getting out of this trouble. In Rev Barber's book, The Third Reconstruction, he talks about this idea. He was president of the state NAACP. And as he moved around the state, he discovered that there were many small groups, and all of them were working hard, but they were small. And he thought, what would happen if I could get the groups together? And so he sat down and he said, I started to sketch a list of 14 justice tribes in North Carolina. We had folks who cared about education, folks who cared about living wages, and others who were passionate about the 1.2 million North Carolinians who didn't have access to health care. We also had groups petitioning for redress for Black and poor women who'd been forcibly sterilized in state institutions, organizations advocating for public financing in elections, and historically Black colleges and universities petitioning for better state funding. I included on my list groups concerned about the discrimination in hiring, others concerned about affordable housing, and people opposed to the death penalty and other glaring injustices in our criminal justice system. Finally, I noted the movements for environmental justice, immigrant justice, civil rights enforcement, and an end to America's so-called war on terror. Any one of these tribes had several highly committed people who'd been working on their issues for years. Some of them had been able to mobilize thousands of people for a particular event, especially when their issue was a hot news item. But Ezekiel's bold vision, Ezekiel the prophet, got me thinking about what would happen if we all came together for a people's assembly. So they did hold such a people's assembly and came out with a shared platform. And what I want to do is stop the share and show you a short film made by the film company Rumor, which um, gives you a sense of how they took this to the next level. And I just have to get back to the film. Sorry, I had it all set up. And then I did something. This will just take me a second. There we go. Thanks for your patience. Here's our film.
You see, our opponents, their strategy is always one of division. The idea of community to us is we. The idea of community to them is them versus us. And it's a strategy. They've tried, and it's worked in the South especially for a long time, but a change has come. We come here every Monday to say, if you mess with the poor, you mess with all people who care about justice. If you mess with voting rights, you mess with all people who care about justice. If you mess with education, you mess with all people who care about justice. And when you mess with women's health, you mess with all people who care about justice. And I didn't have any physical sisters, but I got a whole lot out here. So when you mess with one, you actually unify us and you bring us together. You need to be around some people that still believe in the possibility of us being one people. I needed to come to church on Monday.
Thank you. Thank you. Thank you.
Let's put our hands together. All of us. My brothers and sisters, this is where it gets really real. She just gave the compliment that makes those who are narrow-minded feel the most. And that is when this sister looks at me and says, "Amen, brother." And I say, "Right on, sister." And as Dr. King said one time, we may have come over here on different ships, but we all in the same boat now.
I drove 6 hours this morning. I was so depressed when I heard what this legislature thinks of me.
My. So depressed when I heard what this legislature thinks of me.
But I came last week. And I was inspired. And I'll come as often as I need to.
You have 2 minutes to disperse or you will be arrested.
Us to go away when the sun goes down. Day or night.
We're gonna stand for what is right.
Day or night. We got to stand for what is right. Around day or night. We got to stand for what is right. Day or night. We got to stand for what is right.
So the Reverend Barber and all of his colleagues worked out this concept of Moral Fusion Coalition in North Carolina. And that's the concept that they've taken national with the Poor People's Campaign. And the Poor People's Campaign points out that there are 140 million poor and low wealth people in the United States of America. And what's important about the campaign is that it brings the voices of all of those, all of the people who are caught in being poor and low wealth. Poor and low wealth is the reciprocal of the concentration of wealth in the hands of a few, that you create a vast number of people who are poor and low wealth. And furthermore, that you leave them without the common resources, without the threads of society that buffer their experience of poverty. So the Moral Fusion Coalition is importantly moral. And of course, the concept of moral has been hijacked by the right, beginning with the moral majority. But Reverend Barber and Reverend Liz Theo Harris and all of the clergy and other moral people who work with them are hijacking it back to say that morality is about how do you treat all the people. I would like to say that at the heart of such a campaign is that you have to know what you're for. And so the Poor People's Campaign is importantly programmatic, that this is not about hot button issues, though obviously there are hot button issues. The demonstration we saw was about a restriction of abortion rights. But you have to get deeper than that. You have to get to wages. You have to get to housing. We're in a nation with a low-income housing famine. We're so far behind on having enough housing for low-income people. And we're looking at an eviction, a mass eviction of all the people who are behind on their rent with, what are we going to do about that? It's been even difficult for people to get whatever little money there is to pay rent to people because we don't have a national registry of evictions. We don't know who's in danger. And of course, we don't have a national registry of evictions because the government has been stripped in order to give wealth to the wealthy. But these are the problems that are determining people's ability to live or die in this society. And so the deep crisis under all the 6 crises and 5 injustices is that we are shattered as a nation and can't think together about how we're going to solve our problems. So we have gone through this splintering of society really literally over and over again. And the task ahead of us is one of reknitting society, of acknowledging that there is a society and that it needs to be reknit. And this is not entirely about issues. This is about people talking to people. So I would like to end just by saying that this is Black History Month, and it's very traditional in Black meetings to open or close such a session with the Black national anthem, Lift Every Voice and Sing. And I would urge you to listen to this Spelman College Glee Club performance, which you can find on YouTube, which is extraordinarily beautiful. And I think is designed to really reveal how the 3 verses of Lift Every Voice and Sing take you through the breadth of the Black experience. And Reverend Barbara Holmes has talked about the Black experience as a geo-spiritual anvil. And I think it's not an accident that Reverend Barber speaks up for a new morality. As somebody who speaks from the tradition of people who have been through this geo-spiritual anvil and survived because they said the lies that are told about us, the oppression that's imposed on us is immoral, it's unjust, and it's lies. That the rejection of what was being done to African Americans by the larger society, the rejection of that has created a core of morality. Not that everybody came through sane, but that the community had a core of morality, a core of understanding of we, a core of understanding of powers greater than ourselves that has helped them to endure. So with that, I'd like to stop sharing and perhaps people can turn on their screens and we can chat.
Well, that's a wonderful, wonderful talk. I just wanted to ask you, I mean, you've done work, obviously internationally as well as within the United States. Um, do you think that the problems of disintegration are greater here? And related to that, are there other countries in which you think solutions have been found that might be helpful here?
Well, I think every country has its own history that it's dealing with, and that to some extent the capitalism is a global force, and part of capitalism, as David Harvey points out, is this process of accumulation by dispossession. So the drive of capitalists is to take without any constraints. In some countries, working people have been more successful at keeping the capitalists constrained, but not entirely. Capitalism is capitalism. So I think that, but if you look at rankings of rich nations, for example, infant mortality, maternal mortality, basically any measure you want to make, we do very badly. So, and that was before the acceleration of all these problems by the Trump administration. So I think the Trump administration really pushed us over an edge, or we're teetering on an edge. I don't know if the Biden administration can pull us back. We're in very serious trouble.
I mean, clearly racism is not a new thing in the United States. And some people have said, well, Trump has just been more explicit in stating things that were implied by other leaders. But there have been other trends that might be regarded as forces for disintegration within the country, potentially, such as neoliberalism. Do you think that there's an issue there that requires attention?
I mean, as I said, when Margaret Thatcher puts forward the ideology of neoliberalism and says there's no society, and that's taken up wholeheartedly in the United States, so that defunding the common good becomes common practice, no question that pushes us towards catastrophe. The New York Times, however, counted how many attacks Trump made and said that it was somewhere between 6,000 and 10,000, depending on how you defined attack on Twitter between 2015 and 2020. I think having the president of the United States attacking people 10,000, let's say 10,000, I'm liberal in my definition of attack, 10,000 times on Twitter, so there's an attack a day or 3 a day, is abusive. I think we were in a situation of domestic violence from the president of the United States. I think that's dramatically different. So in a frayed society, we took a hot iron to it and burnt the fabric. That's how I see it. But we weren't in good shape before Trump got elected. So.
Hi, I had a question on the issues that you're talking about today and where you think the country is. What specific implications are there for healthcare, especially for healthcare for minorities?
Well, of course, I'm a social psychiatrist, so I'm working on the social determinants of health, not healthcare. And, so I like to think 80% of what's going on is about health is going on in that domain, the domain of social determinants of health, and healthcare is the 20%. So, I think the big picture of terrible growing wealth inequality, destabilization of communities, tearing apart social bonds over and over again, that's the big picture driving health. And what became very clear to me when we followed the pandemics of Harlem in the 90s. So there was the AIDS epidemic, the violence epidemic, the crack epidemic, the mental illness related to crack, it was just, you couldn't keep up. And the thing about creating an ecosystem that can pump out new diseases is that healthcare's got to run after the new diseases, because you don't know how to treat them. And then you don't know how to treat the new diseases piled on top of the other diseases. So COVID kills people who are obese, and we've had a terrible obesity epidemic. So now we have to figure out COVID and obesity. So you're just always in that situation. It's a hamster wheel. I think that having a society that's so weak pumps out diseases faster than we could imagine how to treat them. So it's devastating for the healthcare system. What you want to do is move the whole curve. And when you move the whole curve, you create a situation where the healthcare system can prosper, the people can prosper. So that's that's one thing that's at stake. The other thing that's at stake is that we're pumping out diseases, and what the people who study these crazy diseases point out is that this is not the big one. The big one will have a mortality of 50%. And if we handle that one as badly as we're handling this one, that's going to be the end of civilization as we know it. So I firmly believe that healthcare is fragile. It's like a beautiful egg, the healthcare system, and it's the job of people like me and all of us to say, no, 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 this egg is supposed to be in a nest, carefully protected. You can't let a virus run wild. You'll destroy your healthcare system. You have to protect your healthcare system. You have to protect your healthcare workers, and you do that by moving the curve. I had a small example. I had the opportunity to create a program both at UCSF and at Columbia to address school failure among medical students. And what was important about the program was that it just moved the curve. It just changed how the whole school operated, and basically eliminated preventable failure. So that's what we have to do in the society in general. We have to prevent preventable disease. This COVID epidemic should not have hit our healthcare system the way it has. That was a collapse of society. So that's how I feel about healthcare. It's delicate. It's that 20% that it does, we want it to do, but we have to do that by doing the 80%.
Thank you.
Thank you for your question. Thank you for turning your video on. It's nice to see your face.
I had a question too, if that's okay.
Sure.
Thank you so much for your talk. Just wanted to get your take on this, in terms of addressing a lot of the ways in which society has failed us in terms of social determinants and just having safe and adequate, like say, for example, housing for people. I think some things that have come up in the healthcare world are that, should healthcare get into the quote unquote business? And I recognize kind of the power of the business word in the business of housing. And that always seemed like, and that's like the future. And like, are we going to get reimbursed for providing housing? Just as like one example. But it just doesn't really sit well with me, because I feel like it's kind of shifting some of the things I feel like our society should care about to provide, like through governmental means, putting it onto a system that's like dependent on health insurance, dependent on other funding, on grants for things like that. So just wanted to see if you had seen that trend. And I guess the question is like, who is best to address those things, and who's, I think we all kind of want it done, but whose responsibility is, and how is it going to be done in the best way?
It's a really important question. I mean, what's crucial is that there was an effort in the 50s, in the McCarthy era, to drive government out of providing housing, to demonize public housing. And as we all know, Roy Cohn, who was McCarthy's lawyer, was Trump's mentor. So this has been going on for a long time. And they basically succeeded. They said only the market should provide housing. I've had a chance to hang out with a lot of developers, a lot of architects, and they are completely clear the market will not provide low-income housing. They can't. The numbers don't work out, is how they put it. So if the market is the only provider of housing, and the market can't provide low-income housing, what happens? You go into where we are now, a low-income housing famine. So whether the healthcare system says, okay, we're going to get into this. How could you provide low-income housing if you didn't have subsidies? And if there are no subsidies, why would it make any difference if you were the developer? It wouldn't. But what I think is fundamentally important is that most physicians couldn't tell you the argument I just told you, because they don't have any structural competence, as Helena Hansen and Jonathan Metzl have pointed out. And you know, I've been basically booed off the stage by physicians because they're like, you know, you're wasting my time. I need to know about molecules. And I was like, as long as physicians have that attitude, it's better that you stay out because you're not helpful. So if you're going to come into the conversation, get some structural competence. I'm not saying you, I'm just saying the field. Yeah, and the field is pretty rigid about that. Helena and Jonathan had asked me to contribute something to the New England Journal of Medicine, and they said it had no clinical relevance because the idea that these social determinants of health are organized in a particular way and have to be managed in a particular way is too far from the biomedical model of the person for them to make the leap. Well, fine, but then don't say you have anything helpful to add to the housing conversation. So did that sound too angry and irritated?
Maybe not angry.
No.
So I have
Thank
a
you.
question.
Yeah.
I'm sorry, it was somebody else speaking. So thank you for a very inspiring talk. You know, I have been recently, as a physician scientist, I have been trying very hard to engage my fellow physicians in this concept that we can and should integrate social determinants of health into our clinical care processes. And the tack that we are taking, we've now conducted a number of studies using a very large cohort that we have access to, is to provide, you know, to remind physicians that they should be asking a lot of social determinants as part of the social history, which is part of the medical history that we teach and that we use in clinical care. And many social determinants are collected there, except we don't think of them that way. We should all know how much our patients can afford medications or healthcare, whether they have health insurance. We usually know whether or not they live in a poor neighborhood, what their family structure is like, what their social structure is like. So we've developed a very simple, straightforward approach of just counting them up. And although the associations differ slightly across endpoints, we've looked at this now and reported it, published it in coronary heart disease, stroke, heart failure, incident heart failure, 90-day mortality after heart failure. And we have the same findings under review for diabetes and for hypertension, incident diabetes and incident hypertension, and mortality in the hypertension paper, which is astronomical. So there's an independent effect of these social determinants that actually is much larger than the risk factors that we usually pay a lot of attention to, like cholesterol or high blood pressure. So I do think there is room for us to continue this push to raise awareness among physicians that they can and should use social determinants. This idea of, oh, it's not clinically relevant. Well, of course it's clinically relevant because these are the very people who have terrible risk factor control. So it's a great way to identify somebody that needs extra attention and extra aggressive clinical management because of their burden of social determinants. So I hear what you're saying about the tone deafness of a lot of physicians, but there are some of us who are really trying to push this agenda forward because I think it's very important. And, you know, some of this work is being recognized by editors of medical journals. So, you know, we've gotten some of our stuff into fairly high visibility journals. So thank you for your work. There are some of us on the dark side who understand it and are trying to push it forward.
God bless you. Keep it up. Structural competence is very important. But I think structural competence, if I may just say, I think it's ultimately, as I see it, structural competence has to go beyond taking a history, a competent history, and knowing when somebody's at elevated risk. For example, there are many ways in which healthcare providers, physicians among them, govern space. So a great deal of urban renewal, destruction of poor African American and other poor communities, was done by hospitals. If we look at the intrusion of the hospital I know best, Presbyterian Hospital, into the surrounding Washington Heights neighborhood, it was described in the 60s as an octopus, and its tentacles have continued to just eat and eat and eat at the neighborhood. That's not responsible. The structural competent leaders would not be doing that. So people have to get to the point of structural competence in which they actually understand that there are structures that they're connecting with that are immoral, unjust, and creating disease, so that they can take charge of their space in a way that's responsible. It's irresponsible now. And so it can't just be limited to, in the clinical encounter, I realized there are 10 risk factors from social determinants of health. Our hospital is a risk factor. Let's take charge of that.
I was very interested in your comment about systemic factors, and particularly the example you gave, how a wealthy person in a disintegrated community has a poorer health outcome than a poor person in an integrated one. One of the problems with the medical model, that I think, is that even when it takes account of the social determinants of health, the tendency is to want to then focus on the individual and try to fix whatever you can fix within the individual, when the problem is often way outside the individual. And in some ways, it's unhelpful.
I think that was Engel's point in proposing the biopsychosocial model, that neglecting the larger systems was unhelpful to the individual. He was talking about clinical applications, as Monica mentioned. So that was in the spirit of what's imposing on the person that we ought to know about in the examining room. But there is that next step that perhaps you all knew or read the obituary for Jack Geiger, who famously prescribed food. And when he was working in the South, and people came in and said, how can you do that? And he said, well, in my medical textbook, it says the treatment for malnutrition is food. And so they backed off. So can we famously prescribe food or housing?
Thank you, Dr. Fullilove, for a really thought-provoking talk. I wanted to, it's both, what's the word I'm looking for? The magnitude of the challenge, I guess, keeps coming back to me and I really found a helpful way of thinking your model of integration and disintegration. And as I was looking at disintegration, I was just wondering sort of how one starts to move back toward integration. I mean, few and weak leaders, maybe we've got some improvement there a little bit now, but small fractured networks, are part of that is, I think, our networked social media infrastructure, differing sentiments that's fueled by, redistricting, concern for self, fueled by neoliberalism. These are such massive, powerful shifts. How does one start to go about undoing them and moving back toward integration?
It's not trivial to say that the Poor People's Campaign has regular meetings, and they're worth going to. Partly because you will hear the broadest array of voices of sort of who's in trouble in the United States, of anybody's meetings. And it's very important to hear those voices, and also because they have advice and they're trying to do this. But, one of the lessons from the runoffs in Georgia was that 10 years of organizing had shifted the political context of that state. And basically is going to save us. If anybody saved us, it's Stacey Abrams. Stacey Abrams saved us because she did organizing. So the organizers who are on the ground are saying, look, we have to be funded for long-term multi-issue campaigns, not hot button campaigns, not short-term, not guaranteed results, but long-term funding for multi-issue campaigns. How can the healthcare system, for example, Monica's work, how can you share that with funders so that they begin to understand that given this, the breadth and depth of this disaster, they have to put their money into that. As you know, funders like to fund people for 3 years or 5 years at the most, but they were talking about 10 years or 20 years of grassroots organizing on multi-issue campaigns that are led by a breadth of organizers, white working people, people of color, people who are living in terrible poverty, all kinds of people who are part of the, that have to organize the people who are suffering and raise up those voices. The country has to face that we've cast 50% of our population basically into despair. How are you going to have a country with 50% of the people in despair? That's not going to work. So I believe that there are many ways in which you can contribute, but advocacy is among them. But knowing it yourself and feeling it yourself and sharing it with your own networks. And hospitals have enormous convening power. So any hospital can convene all the communities around it and say, let's start to put together a community connection. Think about epidemic preparedness, just as one topic. If the big one were to come, you need to be able to mobilize people. You need to be able to mobilize government. You need to be able to get them to listen to the best possible scientific advice very quickly. So just as a thought experiment, what would, if you were to network your whole community with that goal in mind, not that there couldn't be others, what do you think it would take to be prepared to save people in the event the big one hits? What would you like to see? What is it going to take in terms of scientific knowledge? One of my doctoral students is working on looking at the shelter system in San Antonio. It happens that some decades ago, wise leaders thought they ought to put together a system to support homeless people in San Antonio. And that system was able to respond to COVID very rationally because it had been put in place and had been working together for 20 years. What could you put in place? That's the big issue. And what if you were able to tell every hospital, in my sense of healthcare as this precious egg, like a Fabergé egg, we have to have people know that healthcare is a Fabergé egg and treat it delicately, treat it with respect. So all the hospitals have to network all their communities to be prepared for the next one, just as a thought. Does that answer your question, I hope?
Yeah, that was wonderful. Thank you.
Do you think that there are some essential things that could be taught to people who are training in clinical fields that would be helpful, other than for their own edification?
Helpful for?
Or facilitating a transformation of aspects of the society with which healthcare interfaces.
I had the privilege of doing my last year of residency at Montefiore in the psychiatry department, but I met some people, some fellow residents who were in social medicine and started going to the social medicine rounds. So I had a year of hanging out with that group of people and learning what they were learning. And so there's a very well-developed, well-established model. And it certainly helped me as I was working in the South Bronx, understand the South Bronx. And then as I was working in community psychiatry and as I went into AIDS research, I felt very well prepared to say there's social structural issues here. I may not know what they are, but I got to look for them. So I think that model is a very functional and was really important in my own life. You know, people say that at this point it's all about systems thinking. And so the other thing that was tremendously important was I trained in family therapy, which is all about systems. And obviously pandemics are ruptures in social systems at the global scale. So if you can learn to think about systems, it helps you to tackle the problem wherever it shows up.
Are there any additional questions? This has been a really challenging session because it means we have a lot to do and to address. But any further thoughts or comments that people want to make?
I have a question for Mindy. Mindy, since the beginning of your career, of course, you're a scholar and more. What improvement has the healthcare system or healthcare in total, let's just keep it in the United States, has improved for, and let's keep it in a population that speak more than one languages, has improved to now? Thanks.
Things have changed. When I trained at Columbia, when I was a medical student at Columbia, it was completely segregated by class. I think it's still pretty segregated by class, but not quite as harshly as it was then. And the faculty was, I think there was one Black faculty member or two, and everybody at the top was white. So everybody at the bottom was Black and brown. So, you know, it was that kind of structural racism, I think, has improved a little bit. But on the whole, it was nicer then. It wasn't as corporate. And I don't think neoliberalism, the penetration of neoliberalism into medicine, has been to our benefit at all. And there's been a lot of technologies, but quite a number of people have written about the ways in which technologies benefit those with more resources, not those at the bottom. And our population is not healthier. And social in the social structure, as I've been talking about today, is decidedly worse. So I don't think we're better off, but I do think there's a lot of people who are worried, and that means that they're going to be talking about this, and perhaps out of those conversations can come a change.
Mindy, please, I want to understand I love your answer, and I want to understand it fully. Please define to me what neoliberalism is. Thank
Sure. you. Neoliberalism is a philosophy of capitalism, and it basically means that capitalists should not have any constraints on how they do capitalism. There shouldn't be any labor unions, there shouldn't be any regulations, and they should just be able to maximize profit, and that the government should facilitate transfers of wealth to the wealthiest people. That's the philosophy of neoliberalism. And it's been dominating capitalist countries since Reagan and Margaret Thatcher. So the mid-70s. It's been brutal.
Yeah.
Yeah, look it up on Wikipedia. They have a very good entry.
Yeah, I love to, I'm the type of person that love to hear the answer from the person directly. That way, reading is one thing, listening and feeling is how I learn best. Thank you, Mindy.
Thank you.
To your point about neoliberalism and academic medicine, there was a commentary in one of the internal medicine journals recently that in the light of the Black Lives Matter movement and the talk of anti-racism programs in all these hospitals, there was a point that they ought to actually try to incorporate their anti-racism agenda, their alleged anti-racism agenda, into their business plans. Because of course, they prefer to talk about it rather than actually do something that is meaningful. Well, any more questions and comments? We're about at the end of our time. It's been a very exciting presentation. And Dr. Fullilove does have a bunch of what look like really wonderful books out there, including one just published this year. I think it was in the chat. And we should all grab a hold of some of them and learn some more. It seems like we could learn a lot. So thank you very much for joining us today.
Thanks for having me. Bye, everybody.
Bye-bye.